First, I will demonstrate the test item clusters for mechanical neck pain that may benefit from thoracic manipulation. First is Fear Activity Belief Questionnaire, activity score less than 12, symptoms less than 30 days, no symptoms distal to the shoulder, and diminished thoracic spine kyphosis. Looking up doesn't aggravate symptoms. And lastly, cervical extension, active range of motion demonstrated by my patient, which is less than 30 degrees. Go ahead and extend your head. 10 degrees, extension range of motion. Now, I will demonstrate the test item clusters for full thickness rotator cuff tear as well as for subacromial impingement. For full thickness rotator cuff tear, you have three special tests: the painful arc, the infraspinatus test, and the drop arm test, which I'll demonstrate right now with Andrew. All right, Andrew, so I want you to put your arms to the side and bring them up as high as you can. Okay. Now, what I want you to do for the infraspinatus test is bring your arms up here to the side like this. All right, don't let me move you. And lastly, what I want you to do for the drop arm test is bring your arms to the side, shoulder length. Apply resistance, don't let me move you. For the subacromial impingement test, the first two tests that I just showed will be the same, which are the infraspinatus test and the painful arc test, with the inclusion of the Hawkins-Kennedy test. So go ahead, Andrew, bring your arm up here like this. Now, I'll demonstrate the test item clusters for mechanical neck pain that may benefit from cervical manipulation, which include if the patient thinks they will benefit from it, if the onset of symptoms are 30 days or less, side-to-side rotation difference greater than 10 degrees, which I'll demonstrate right now. And you rotate your head to the left. Now to the right. And lastly, PAs. So, Andrew, go ahead and lay on your back, head towards me.
Ooh.
Now, I will demonstrate the test item clusters for cervical radiculopathy, which include the ipsilateral rotation less than 60 degrees on the symptomatic side, Sperling's test, distraction test, and the upper limb tension test, which I will demonstrate in that respective order. Now, I will be demonstrating the upper limb neurodynamic tension test number 1, specifically testing for the median nerve. I will now demonstrate the apprehension test, assessing the anterior glenohumeral joint capsule instability. Watch while I demonstrate. I will now demonstrate the bicep load 2 test for the presence of superior glenohumeral labral tear. Don't let me move you.
Ouchie! Pain deep in my shoulder.
I will now demonstrate the sharp pressure test for the presence of upper cervical spine instability, specifically assessing the integrity of the transverse ligament. I will now demonstrate the carpal compression test for the presence of carpal tunnel syndrome. Apply compression for 30 seconds. Alright, so when differentially diagnosing between a rotator cuff tear / subacromial impingement versus a C5 radiculopathy, I'd be able to obtain these findings from performing a subjective interview, fundamental tests, and special tests. And one of the most important information I'd be able to gain would be from the subjective interview. So I'd ask questions such as, do you have pain and where? Do you have pain with repetitive overhead activities? Or do you have any numbness, tingling, radiating pain going down your arm? I would then perform active range of motion, passive range of motion, and passive range of motion with overpressure, both in the cervical and shoulder joint area. And then for rotator cuff tear, you'd most likely experience isolated weakness. Most commonly affected is the infraspinatus and supraspinatus muscle, so shoulder abduction, external rotation would be weak. Based on the subjective interview and the fundamental tests, I would have already performed the test diamond clusters for rotator cuff tear. So, for instance, with shoulder abduction, I'd be able to see if they had a positive painful arc, and then while coming down, I would be able to see if they had a positive drop arm test. Also, I'd be able to assess their infraspinatus test by doing external rotation manual muscle testing. If they had pain with the repetitive overhead activities and had a positive painful arc as well as a positive infraspinatus test, I would consider subacromial impingement, and then I'd perform a Hawkins-Kennedy test. Now, if they mentioned having numbness, tingling, radiating pain down their arm, and they had cervical rotation, active range of motion less than 60 degrees on their symptomatic side, I would consider cervical radiculopathy. And usually with C5 cervical radiculopathy, you experience diffuse weakness, and all the muscles innervated by the C5 spinal root all would be affected. Also, you'd notice sensory loss on C5 dermatome, so on top of the shoulder and the lateral aspect of the upper arm. And also, you'd see diminished bicep reflex, which you wouldn't see with the rotator cuff. And then also, so if I was thinking more cervical radiculopathy after all these findings, I would then perform special tests such as a Sperling test, the upper limb tension test, and distraction, all to kind of help be able to differential diagnose between these two.